Hello, everyone. Thanks for coming. Medicine Grand Rounds. I'm David Scarborough from Endocrinology, if you don't know, but I think you pretty much all know me. Not loud now? Oh, feedback.
Keep your cell phone. Keep your cell phone out of your pocket.
I always forget this, not always, but almost. That should do it. Okay. Sorry about that. All right. So I have nothing to disclose. I like to put in my Nature of Science reminder from Bertrand Russell that we're not aiming to establish immutable truths or dogmas, but rather to get closer to the truth gradually as we go. That's my protest against the phrase settled science, which I think is an oxymoron. All right, topics covered in this talk, the hypothalamus and obesity, and then multiple symmetric lipomatosis, gigantomastia, and if I don't run out of time, a little lanyap. So here's the almost obligatory slide about how we've become progressively more obese in America. Over time, the BMI has been going up, getting higher and higher, and trailing along has been type 2 diabetes, which of course is a scourge in our area and everywhere pretty much. This is a slide I took from Dr. Bray, George Bray from the Pennington Center. And when I initially stole it, it was not as crowded, and I've had to keep adding morbidities to the periphery here, and it's pretty much full and has spilled over into text at the bottom, which now just has dots. There are just so many morbidities that go along with obesity. One I just added was thyroid cancer, which I don't know how that works, and I don't know how some of these other things necessarily work, but they do seem to travel with obesity. So lots of health care to be delivered in this area. And I sort of sum this up by saying obesity has exploded. It has increased prevalence here and worldwide. And that, in turn, has led to more funding and more research, which is great. And this has, in particular, extended to the study of adipose tissue, which didn't seem to interest most people. And partly, I guess, because the histology seems so boring. Fat cells just seem like little bags of fat, and what could be going on there of any physiologic interest? And then you have the practical things, which is if you try to work with large amounts of fat in the lab, just as if you try to work with large amounts of stool, you have a fairly unpleasant lab after a while as things get rancid and smelly. And you know, these things affect lab scientists just like they affect anybody else. But now, adipocytes have their own journal called Adipocyte. And we know that adipose tissue produces a whole bunch of hormones and therefore of interest to endocrinologists. And it has both efferent and afferent innervation, which is pretty funky. And that makes it of interest to neurological and neuroscience types. We also know that there are different types of fat and that these different types can be in different places around the body, and they may act differently depending upon what type they are and where they are, so getting more complicated. Here's the where is the fat slide. If it's below the waist, as here, or around the waist or in the belly, as here, it does make a difference to what the consequences of carrying the extra fat are. So here's one from the New England Journal a few years ago, and it's the relative risk of death by waist size after adjustment for BMI. So we've adjusted roughly for how big a person you are to start with. And then if we do this, we can see that both in men and in women, the relative risk of death pretty much goes up as the fat in your middle goes up. Now, we don't know what that's about necessarily, but it's an observation. That's pretty robust data, if you ask me. So we don't understand this, as I said. A lot of things have been described, however. For example, the visceral adipose tissue, that's in the abdomen, does correlate with higher levels of CRP and IL-6 in type 2 diabetics. And there are a lot of studies that specifically implicate the visceral fat as more harmful than sub-Q fat. Now, not all studies, but many studies. So here's one that was in the Annals last year. Normal weight central obesity, implications for total and cardiovascular mortality. So they did analyses of NHANES 3, and they came to the conclusion that central obesity gives worse long-term survival compared with participants that have a more normal fat distribution, regardless of BMI category and even after adjusting for other potential mediators, at least those that they could think of and check for. So here's I don't know how many times people have used this. I'm just joining the large crowd that has used this little graphic. But the point is, from the CDC, that we've had lately, meaning the last half decade or so, over 30% of our population in the obese category and over 2/3 in the combined overweight and obese category. So we have a big issue here. And this is just getting to the types of fat issue. We have brown fat and white fat. And this got a big boost thanks to PET scanning, which discovered that adults, in fact, have some brown fat. It was interfering with scanning for the spread of lymphomas, and they had to start bundling up the patients so that they wouldn't activate their brown fat and have the brown fat light up around the neck and through the central chest, masquerading as neoplastic lymph nodes. So we now do know that you can have a lot of uncoupling protein 1 in brown fat, and you can find it in adults. So here's the brown fat stain for UCP1 versus the UCP1 in white fat. Now, if you're not aware of UCP1, this is just one of several molecules that will allow you to waste chemical energy, quote, by generating heat rather than generating ATP. Now, if you generate ATP, then maybe some of this energy gets stored in white fat. Here's our white fat. On the other hand, if you don't harvest that chemical energy and it gets just expended as heat, then it doesn't make you fatter, it just makes you hotter. And of course, you can sweat and sit in front of a fan and otherwise dissipate your body heat. So fat depots and fat cells. So not only do we have the white adipose tissue and the brown adipose tissue, we also have, as it turns out, bright or beige fat. This is the combination of brown plus white, so it's mixed, hence bright fat. Or if you want, you're mixing white and brown and getting beige. So turns out we have these kind of mixed fat depots, and that they can evolve a little bit. They can get browner or less brown, depending. We have the visceral adipose tissue, the sub-Q adipose tissue, and of course there is marrow adipose tissue, and there's more. There's many more. The marrow adipose tissue not only makes a good soup, it turns out, but it does other things. And you could ask yourself, what's it for? I don't know. I had never really thought about that. You know, oh, look, there's fat in the marrow. Must be like, I don't know, filler? Or is it actually doing something physiologic? So ordinarily, it's about 10 to 15% of your total body fat. But as you get older, or if you calorie restrict or fast, then it turns out it becomes a larger percentage, and it can go as high as 1/3 of your total body fat in certain circumstances. Grossly, it looks just like regular white fat, but it turns out that some of it will respond to regulatory stimuli, such as calorie restriction or adrenergic stimulation, and then some of it kind of doesn't. So it's not homogeneous in terms of its physiology. Not only that, but if you look even in the same bone, for example, I think it's tibia, could be femur. Anyway, one of the long bones of the legs has been studied, and the fat that's kind of more distal behaves differently than the fat that's more proximal in the marrow of the bone. So this is getting more complicated and interesting all the time. So here's an older slide that shows white fat juxtaposed to some brown fat. So here's the brown fat, here's the white fat. The brownness of the fat grossly seems to traffic with the mitochondrial content. Lots of it in here, very little of it, relatively speaking, in the white fat. This white fat has been stained for tumor necrosis factor with a brown pigment, and so that's what you're seeing here. And in amongst the adipocytes, you do have macrophage-like molecules that are involved in this production of inflammatory mediators. And this has got something to do with insulin resistance, and it may have something to do more broadly with the nature of the metabolic syndrome. So here's a slide that's taken from the Handbook of Obesity, edited by Dr. Bray and Claude Bouchard. And these are Louisiana folk at the Pennington Center. So here they have a figure in their chapter on inflammatory causes of obesity and metabolic disease by these fellows, called meta-inflammation. And they're pointing out that you have inflammation in a variety of organs, such as the peripheral fat, where you get increased insulin resistance. You have it in muscle, where you get insulin resistance and adiponectin resistance. You have it in the vasculature, where it seems to promote vascular disease. You have it in the liver, where it gives you adiponectin resistance. And in particular, you get increased glucose production from the liver, which of course contributes to hyperglycemia. And then up here they have said, oh, and by the way, there's inflammation in the brain, even scarring perhaps, and this is associated with leptin resistance and decreased sensing of hyperglycemia. So we'll come back to that under the heading of hypothalamus and obesity. So here's a netogram, and I'm not quite sure when he made this one. I didn't find it in my neurological system from 1958, nor did I find it in my endocrine system from 1965. So apparently he did it somewhat later, but he's made a picture of the hypothalamus here, and we have labeled some of the areas. And here we have the ventromedial nucleus right here, and if you lesion it, you get a hyperphagic and irritable cat. Rage, it says here. On the other hand, if you lesion the lateral hypothalamic area, as in these lesions here, you get an animal that doesn't eat and gets very skinny. My first encounter with this phenomenon was in an experimental lab where This is a picture of a hyperphagic rat, but the ones I was dealing with looked more like this. They would get kind of dirty looking as well as very fat, and they were really irritable. And my job one day was to help give them injections. So you had to grab them and hold them while they were injected. And I was wearing small leather gloves and then big, heavy leather gloves. And after practicing mentally the grab, you know, grab the suckers, push the front paws underneath the jaw to keep the teeth away from your hands, and then hold them firmly, let us call it, spasmodically, let us call it. And the first one I did, I got him, and we gave him the injection, and then I held him over the cage, figuring I would let gravity drop him into the cage. This was a mistake. Gravity needed help, because when I dropped him, he bit me through both layers of gloves on the way down and drew blood. So everyone thereafter got the reinforced drop, let's call it. So that was my first exposure, and it was bilaterally lesioned hypothalamic lesion rats. So, and then you go on in life, and I became an endocrinologist, and I was seeing people that had disease in this area. And here's a paper from 2003 pointing out that childhood craniopharyngioma leads to about 50% occurrence of obesity after tumor surgery, more likely to happen if the tumor infiltrates the hypothalamus. And what I found myself was that I had a number of patients, not like everybody, but patients with large pituitary tumors that extended up and were displacing structures in the hypothalamus. Sometimes they would gain enormous amounts of weight after they had their surgery. And these were folks that had been lean prior, so it was pretty clear that something had happened related to the surgery that resulted in their obesity syndrome. Now, going back to the ventromedial hypothalamic lesioned animals, this is from the Journal of Physiology in 1981 from some psychologists at Yale. And they said, well, you know, intragastric pear feeding fails to prevent obesity or hyperinsulinemia in rats with these lesions. So you could imagine a lot of ways that these lesions led to obesity. Were they eating more? Were they exercising less? Was their basal metabolism less? You could think of a number of things along this line. So what they did is they said, okay, and they went to a lot of trouble. The apparatus, which I haven't shown you here, was quite something, where these animals had no friggin' choice but to be getting a certain number of calories at a certain time of day, every day, and it was more calories than they needed, and so forth and so on. Or you could do it the other way, just not enough calories than they needed. So no matter how you did it, it turns out that that wasn't the key variable, or there were other variables that could wash it out. So not just, oh, well, let's eat more. That's not the story. There's more to the story. Okay, which leads to one of my favorite topics, which is the old notion that it's all about you eat too much and you exercise too little is way oversimple. So this is a little cartoon from well-known people at Harvard in Cell 2001. So yeah, it's true that energy intake matters, and that includes feeding, and that energy expenditure matters, and that includes thermic effective food, voluntary exercise, resting metabolic rate. But there's this other thing, which is the basal metabolism, And then there's what's called adaptive thermogenesis. And that can involve things like the uncoupling proteins and perhaps even other things. And this is not so simple as how much food passes your lips. It's also how much energy is harvested from the food that passes your lips. And that can vary in ways that we maybe haven't been aware of. So here's a slide from the Swedish obese subjects study. And these are people that got gastric banding or gastroplasty or gastric bypass. And this is where they started. This was their basal weight, which was too heavy to some level. And then they had a control group that didn't get surgery. And so they were also starting out on the heavy side. And then the surgerized patients get this terrific weight loss, 30% of their body weight in the case of the gastric bypass. And they managed to keep most of it off, although you can see there is a drive to regain over the period of 2, 3, 4, 6 years. Then they sort of steady out. These folks, it's a similar pattern. They lose 6 months a year, and then they're regaining. This was good for them. Their mortality ratio went down. And I would just say, why were these people staying the same? Did they have a set point for their body weight, perhaps, even though it was a too high weight? Now, here's a study way back in 1993. This is a behavioral guy that studies obesity, very good. And they did very low-calorie diets, by which they meant less than 800 calories per day, or behavior modification at 1,200 kilocalories per day, which is restricted. And they could have a combined, do both. The treatment period was, however, just 6 months. And they got very nice weight loss, not like gastric bypass, but still pretty good. And then we stopped the treatment and let them eat ad libitum, as we say. And they regained very nicely within the next 6 months. And by the time you're out to 4 and 5 years, they've actually overshot a bit where they started. And this has been one of the great problems with all the treatments for obesity, is this inability to sustain a weight loss that you get folks to achieve however you get them to achieve it. Surgery has done better than anything else in that regard, but as you saw, it's also prone to the same phenomenon. So here's a study that was done at the Pennington and at Harvard, where they did intensive and prolonged coaching, and they also varied the mix of the food that was in the diet. It was called the Pounds Lost. Here's Dr. Bray again, Dr. Ryan also from down at the Pennington. So 800 patients who were overweight without diabetes. They got a low-energy diet with a varying content of macronutrients. And they did very fancy, doubly labeled water resting energy expenditure measurements at several points. And they did say here at the bottom of their abstract that it did fall significantly with weight loss, but was not related to diet composition, and adaptive thermogenesis was evident early on, meaning that the energy expenditure dropped, but that by 2 years things had kind of bounced back. So here's the data. Here's the initial treatment during which the body weight went down quite a bit, about 7 kilograms, and then it had started to come back at 2 years, although they hadn't got to complete regain. Not a lot of difference between the different diet types. And then here's the resting energy expenditure, which took a nice little drop with the initial weight loss, but had recovered almost to baseline by the time you were at 2 years, even though the weight was not yet there. So this is just data about which one can hypothesize as to why it's being observed. So here's some more in the same vein. The diabetes prevention program was a famous trial where people had some lifestyle stuff that was fairly intensive, or they were put on metformin, or they got a placebo. And these were folks that basically had what we would call now pre-diabetes. They had a little bit of elevation in their fasting sugar or a little bit of glucose intolerance, but not enough to be considered diabetic yet. And they followed them to see if they became, frankly, diagnosable as diabetics. And when this was initially reported, these are years, 1 year, 2 years, 3 years, 4 years. They were initially reported right about in here, where the difference in the diagnosis of diabetes was a difference between, say, almost 30%, and then down here, maybe 12% or something like that. So you had had a third to a half less progression to diabetes with the lifestyle than you had with the placebo. So, oh, this looks highly worthwhile. The only problem is if you follow it out to 10 years, you find that the difference is now between like 50% and almost 40%. So now it's a lot less. So, and that's, this is the follow-up. So here again, what's the phenomenon? The phenomenon is you do an intervention, you get a good result, and then it tracks back up to something that's not too far off of where they started. And could you call this their set point? In other words, we come back to the set point. And these, again, were people, they were actually a little on the overweight side to start with, so they're getting back to a too high set point. Here's another one. I'm about out of these, you'll be pleased to know. But this is a meta-analysis of weight loss clinical trials with a minimum 1-year follow-up. So what do we got? Advice alone. Worthless, So just telling the person, you should lose some weight. This does not help. Evidence-based medicine tells you, save your breath. Just not helpful. Anyway, so exercise alone, guess what? Not too helpful either. So not that it's bad, heaven knows it's good, but for weight loss, not that great. Anyway, diet plus exercise, so this is better, but it tends to regress over time. So what's working better? Well, here's the very low energy diet, and then it works better than these things. On the other hand, it regresses quite nicely over time. Meal replacements, they're helpful. What else we got? We've got sibutramine, which is a mild adrenergic agonist. And look, as long as they were given it, it was still working. Here's orlistat, which is a fat malabsorber, and it also gives a more sustained response, which brings me to one point related to the objectives that I said were the objectives of this talk, which is other than surgery, the other thing that works is keep giving them the drugs, which we're not allowed to do, especially here in Louisiana. And Dr. Bray has likened this to the stupidity of saying, well, I'm going to treat hypertension, but once the blood pressure comes down, I'll just stop the pills. Well, unless you have ameliorated the cause of the hypertension, then it's going to come back. And you didn't with the pills that we usually prescribe. Well, by the same token, obesity is something that tends to recur physiologically without the pills, unless you can somehow or other get at it at a more fundamental level. Okay, well, there was one more. Okay, the impact of continued intervention on weight, 5-year results from the weight loss maintenance trial. And this is brand new. This just came out like now in the journal Obesity. And this is a group included Hopkins, Duke, and Pennington. And they had tried to continually encourage people through PC or personal contact to keep weight off. And this is follow a diet, exercise more, and come talk to us about it, and we'll reinforce it, and we'll cheerlead, and so forth, versus self-directed, SD, which is we give you handouts and things. Now, they had a initial treatment period that was 6 months. You know, why 6 months? Well, because, of course, that's where the nadir usually happens in these kinds of things. So they did the 6-month thing, and then they either continued to encourage or they just let them have the handouts. And over, woohoo, 5 years, guess what? All this effort made some difference, but not that much. So this is the kind of data that, and all the stuff I've shown you before, that leads to the question, what's going on here? What is it that makes it so difficult to hang on to loss that you've achieved, often with a lot of effort, thank you very much. So why is it so hard to keep the weight off? Well, there are all kinds of reasons have been suggested, and I think they play a role. The observation is that once excess weight has been gained, it does seem to be defended physiologically somehow or other as a new set point. Now, this is not invariant, but it's the common observation. And by the way, if you look at folks who have never been overweight, let's call them the lean and healthy folk, if you calorie restrict them and force a weight loss, they will usually gain it right back to where their set point is as soon as you let them eat ad lib. By the same token, if you sort of forcibly get them to eat more than they should, and you can do this by bribing them and various other means. You don't have to put down a tube like was done with the rats. But you can get them to eat more and gain weight, but then as soon as you take away those incentives or limitations, they'll take it right back off, back down to their set point usually. So this gives you this notion that there is a regulatory mechanism at work that will tend to move you to a determined point and call it the set point. It can be a healthy place or it can be a too high place. Again, how would this work? That's the question. All right, now this brings me to the Endocrine Society, which was in Boston in 2011. And at one of the sessions, there was a speaker, Dr. Schwartz, Michael Schwartz, from the University of Washington in Seattle. And I was sitting in the front row because he was going to talk about obesity, and I was obese. And one of my fellows, our fellows, Claudio from Venezuela, was also there, and he was carrying more weight than he needed. And so we sat next to each other in the front row to hear what this was about. I'll just mention that Dr. Schwartz is the Robert Williams Endowed Chair in Medicine. This is Dr. Williams himself, and this is his textbook of endocrinology, now in its 13th edition. So he's got a nice spot. I haven't got time to tell you about Dr. Williams, but this was one character, I'll tell you. I did get to hear him give his Cushing's lecture in the same year that he died. That was lucky. Anyway, we're there, and Dr. Schwartz is talking about how this might work. And as a good academic scientist, he, the following year, made sure, January 2012, that it was in print before he could get scooped by what he said to us at the Endocrine Society. Anyway, so here he is, Michael Schwartz and all his cohorts, and he says, obesity is associated with hypothalamic injury in rodents and humans. And this is what he told us at the talk. And he's explaining to us that being obese and eating a lot of fat will cause inflammation and scarring in the hypothalamus, which will prevent you from being able to lose weight, or will make it inevitable that you regain weight if you have lost weight. And Claudio and I looked at each other and said, we're screwed. You know? So that was a down moment for the obese as far as I'm concerned. So anyway, here we are. So this is some of the data that was ultimately published. So we're giving either chow or a high-fat diet for 7 days, and we're seeing activation of the microglia, which are sort of the resident macrophages in the neural tissue of the hypothalamus. And in particular, this is in the medial basal hypothalamus, down in that arcuate area that we talked about before. The high-fat diet, just so you know, was about 60% of calories from fat and about 20% carb and 20% protein. Here's similar stuff looking at staining for astrocytes. So here's chow at 1 week. Here's 1 week of high-fat diet. And of course, the astrocytes are like having a party here. Here's 2 weeks of the high-fat diet. Again, a lot of it. 3 weeks, well, okay, whatever you would call that. And then we go to 8 months. So here's 8-month control. Here's 8 months high-fat. And we certainly have what you would call astrocytosis in the hypothalamus. So then they also looked at the medial basal hypothalamus of obese humans with some MRIs, and they were comparing the signal ratio between the medial basal hypothalamus, which is in here, versus, well, actually, it's there, and then this is just an area of brain presumed to have nothing to do with energy balance for control. And they got a R value of 0.38. Lots of scatter, but still, you know, easily statistically significant.
Did you ever look back to see if those changes were reversed?
This is a good question. And the answer is they seem to be somewhat reversible, which kind of goes against their hypothesis, and I'll come back to that. So here's another study that they did. Hypothalamic gliosis is associated with obesity and insulin resistance. This is last fall. And here again, they got correlation coefficients with BMI, about 0.3, and about 0.3 for insulin resistance in the whole organism. And this was in persons, not rats or mice. So this is back to their original study where they're looking at what happens to POMC neurons, pro-opiomelanocortin neurons, in the hypothalamus. And this was, again, in the animals. And they found that you experienced loss of the POMC neurons with this inflammatory process. So what they were getting at is that in the hypothalamus you have some neuronal populations that have been implicated in appetite and energy balance. The AGRP ones tend to promote appetite and weight gain, and the POMC neurons tend to do the opposite, to limit appetite and promote weight loss. So if you're losing these guys and keeping these guys, then presumably you're going to tend to eat more and get fatter. And anything else that's integrated here that's related to energy balance. And that includes things like, sympathetic tone and other things. And what they're saying is this high-fat diet leads to neuronal damage and to activation of the glia, this inflammatory process, and this in turn promotes increased body weight. Now, of course, it's a lot more complicated because as soon as you get away from these, eat more, eat less neurons that are in the arcuate, they project to other areas like the lateral hypothalamic area, but others where there are other neurons and other neurotransmitters that are involved in this elaborate regulatory mechanism. So here's another figure from the Handbook of Obesity. And this is showing, again, this is the third ventricle. Here's the arcuate nucleus, suprachiasmatic nucleus for circadian rhythms. Here's the lateral hypothalamic area. And then we've got projections that are going to other places than just within the hypothalamus. Here's the paraventricular nucleus where we're regulating some of the pituitary functions. These things actually project down to here, but never mind. So they say that this is, by the way, where is it? A highly simplified diagram of what we already know about what's going on with all of these different pathways within the hypothalamus. So here's one more recent. This one is from Glia. Hormones and diet, but not the body weight per se, control hypothalamic microglial activity. And here's Dr. Schwartz again. So we're finding out that things are more complicated with this hypothalamic inflammation model. But I thought this was interesting. In this study, they found that GLP-1 receptor agonists reduced this microglial stimulation. Now, this is not something that you see on the slides that we show talking about, why to use GLP-1 agonists like exenatide and so forth. We don't say, oh, well, they decrease hypothalamic microglial activation. So, there may be some more complexities to even the drugs that we've just started to use than we realize, but, remains to be determined. And it's more complicated still. This is one showing that there are some cells that are called the tanocytes that are right smack on the third ventricle. And these guys can project to the ventral medial hypothalamus. And they do glucose sensing. And they can have stem cell-like activity and give rise to new neurons. So yet another way that stuff could be happening in the hypothalamus on a dynamic basis that could affect diabetes and energy balance and so on. So here's a recent review from one of Dr. Schwartz's co-authors saying that hypothalamic inflammation shares common features with obesity-associated peripheral inflammation, but the involvement of unique CNS cell types identifies it as fundamentally distinct. And then they go on to say there's considerable evidence that there's a pathologic role for hypothalamic inflammation and gliosis, but recent conflicting data have muddied the waters. Oh my. Nevertheless, they still like the model and they think it will turn out to have importance in terms of regulation of weight gain. And so then I go back to the Endocrine Society this year, and Dr. Schwartz was back giving a talk. It was in Boston again. We've come around to Boston. And his talk was going to be Obesity Research, Current Science, and the Path Forward. So I went to that talk. And in that talk, he didn't emphasize the hypothalamic inflammation so much. He had moved on to talking about some of the individual neurotransmitters that he thought were involved in satiety and so forth. And that was where his emphasis lay. And as I was listening to him, I was thinking back to the talk in 2011 when Claudia and I looked at each other and said, we're screwed. And in the meantime, here's 2011. The Endocrine Society would have been right about there. And I did go for a while on a vegetarian diet, and I lost a little weight, but it didn't kind of work for me that much long term. And right about here, I went on a low-carb, higher-fat diet. And this is about what my nutrient breakdown has been on this diet. So high fat as a percentage of calories, close to the high-fat diet in the studies of Dr. Schwartz. My carbs, however, are considerably lower. My protein about the same. So this is not high protein, it's sort of normal protein. So what's different? Well, this is calorie restricted in addition to being carb restricted. And his diets were not calorie restricted. So if you had the right mice or the right rats that would overeat a high-fat chow, then you would get the kind of stuff that he was showing. On the other hand, other strains don't necessarily do this. So science is complicated. The other thing is that if you try to do it in primates, it kind of doesn't work. Oh, well, that's not good news for the hypothesis. And it turns out that most of the primate studies, if you give them any food, they'll get a little fat. And I don't know whether they're bored in there and they eat out of boredom like I do. I don't know. They get fat for other reasons. Anyway, so I'm just tickled that whatever hypothalamic inflammation I may have been suffering, I was still able to lose weight despite the high percentage fat diet. Oh well, we'll see. Okay, so that's the hypothalamus and obesity. Now what about multiple symmetric lipomatosis? So I got to see a patient who was referred. She was a 56-year-old nurse and she had supraclavicular fullness, and they were concerned that she might have Cushing's, hence sending her to endocrinology. Turns out she was born with doubled kidneys and ureters. Don't know what that was about. They took out the extras over time, so she was down to just 2 of each when I saw her. She had 3 kids. She had age 20 a son, age 30 a son, age 37 a girl. And then about 4 years prior to her referral, she had a cervical fusion for chronic neck pain. And at that time was diagnosed with essential thrombocytosis. And she also began to notice that she had increased fat in the neck and the axillae. So when I saw her, she did indeed have supraclavicular fullness, kind of filled up the fossa, both sides, and it went all the way out to the tips of the clavicles. And she could also kind of feel it underneath her arms and kind of within her neck. She didn't have a posterior cervical fat pad, and she had nothing else that looked like Cushing's. So I was underwhelmed that she had Cushing's. I did test her, however, and the labs were negative for any sort of Cushing's. She also had a complaint of painful neuropathy, and was in fact seeing a neurologist for this, and she had migraines, and he was also treating her for those. So, did an MRI of the orbit, face, and neck, and it showed prominent fat tissue in the supraclavicular areas and at the bases of the neck. No specific masses can be seen, and the brachial plexuses appear to be okay. And here's her MRI. Here's her fat in there and some fat in the neck. So I did a literature search because I didn't know what she had, and what I found was something called bilateral symmetric lipomatosis or multiple symmetric lipomatosis, first described about a century ago, called different things, including Madelung's disease. And what's different about it is that it's not lipomas. It is fat tissue, but it's not encapsulated. And this lets it infiltrate spaces. And it can infiltrate around muscle and other structures. It can be even in the eye, the larynx, the mediastinum, can be sub-Q and other places. And globally speaking, it's about 4 to 1 male, and it can be associated with both alcoholism and with a neuropathy fairly commonly. So minimal to no effect on insulin resistance or lipids, even if there's quite a lot of it if you add it all up. My patient had no alcoholism history and of course was female. So here's a male with one variant of this syndrome. And as you can see, this is more than usual up here. And yet his legs are nice and skinny. Here's another patient from another series, and they've got it all over the thorax, and they do have this area at the posterior base of the neck. Here's a female patient, and she's got a pretty nice fat pad there, but she's also got this thing where it's all over the back, including across the top of the back. It's down the arms a little bit, and so forth. Interestingly enough, not in the breasts. So how do you treat this stuff? And people have tried a lot of things, and they haven't had a lot of luck with a lot of things. They've tried all sorts of stuff. So mainly it's been treated by surgeons, just going in and taking out as much of it as they could. And more recently, it's been proposed that abnormal fat cells are expressing mutations that involve mitochondria. So here are a couple of the papers, one from Mitochondrion, which I have not yet been willing to spend $30 to get my hands on. But they followed 7 patients for 8 to 20 years that had cervical and other fat deposits of varying severity. They all had neuropathies and some had myopathies. The cases were gradually progressive. 5 of them had a point mutation, a particular one that was mitochondrial DNA, and they took out some of the fat tissue from a couple of people and found brown fat markers. UCP1, a brown fat marker, and then this one. Here's another more recent study where they looked at another syndrome involving fibrillary mitochondrial things and found some of it. So maybe there's a story there. Then we're going to have a few minutes for gigantomastia. So I got a patient that had this as well. This was February 2009. She was 20 years old, sent to us from Dr. Lee, who was running the breast clinic. She had some galactorrhea and she'd had massive breast enlargement. Now, she had delivered a son about a year prior, and that's when the breast enlargement started. Someone gave her a trial of bromocriptine because of the galactorrhea, but it didn't seem to affect the breast enlargement. Around this time, she also had a DVT, although they didn't find any heritable coagulopathy or anything to explain it. So she had a history of a seizure disorder, was on phenobarbital. She was taking Lortab because she had a lot of back pain caused by the very large weight on her chest from the breasts. Her breasts were indeed massively enlarged, so much so that the skin was splitting, exposing the subcu tissue and getting superficial infections. We did a bunch of lab work on her. Her prolactin was normal or minimally elevated. Her estradiol were low. ACTH stim was normal, IGF-1 was normal, thyroid axis was normal, and MRI of the pituitary was normal. So look this up, and it turns out it's been described, and it's been called, gigantomastia. And it tends to happen during puberty when your estrogens are surging, and or in relation to pregnancy when you've had a high estrogen state. On the other hand, getting the estrogens down doesn't seem to slow it down much other than in a few cases. So here's a case series that had 115 patients that they collected from the world literature 1910 to 2006. So this is not happening just all the time. And they found 57 happened in the pubertal period, 41 were related to pregnancy, and then others they couldn't figure out much unless maybe a drug had caused it. Common symptoms: pain in the breasts, ulceration with infection, postural problems, back pain, and chronic traction injuries to the intercostals that can lead to loss of nipple sensation. So here's some pictures. This is one person. Here's someone that had enlargement during pregnancy. This is 22 weeks, this is 34 weeks, and you can see they had to get a little further away to get the breasts into the picture with the second one. They were still enlarging. And here's a lady who is bent just about double with these enlarged breasts. And then here is an 11-year-old girl who has developed this syndrome where we've started to get the ulceration and the infections. And you can imagine how miserable this is for a young person. So it's quite awful for the folks that it afflicts, particularly when it's, well, anyone really. So, and this has been treated with bromocriptine, medroxyprogesterone, tamoxifen, danazol, and there are some reports of positive effects, particularly in the juvenile type, more so than in the pregnancy-associated type. But still, it's one of those things where the main thing that gets done is plastic surgery. And again, you can ask yourself, what the heck is going on? And I'm hopeful that we'll start to figure some of this stuff out, because there are a bunch of these other syndromes, which I haven't gone into, where you can have the upper part of the body getting proliferation at the same time that the lower half is having a lipodystrophy, and vice versa, and so forth. So it's obvious that there are physiologic control mechanisms. We just don't know anything about them. And so fat is a lot more important and complex a tissue than we had thought that it was. So here's my quick lagniappe, which is we have a new hormone in the world of endocrinology. I don't know about you, but I thought when we got the genome, we were kind of done finding hormones and other proteins and things. But no, and the story here was we knew about the protein and the gene. This is a cleavage product of the fibrillin precursor. And people had just sort of ignored it. They knew it was there from the genetic descriptions of the fibrillin gene, which was more of interest in Marfan's and some of the other connective tissue conditions. But it turns out these folks were studying folks that had neonatal progeroid syndrome, where they don't deposit fat in their face, and that makes them look old. Okay? And in studying them, they found this stuff, which it turns out is biologically active, comes from fat tissue, goes to the liver, and promotes glucose production from the liver. And this happens apparently in all of us every early morning. And they have called this asparsin. And this article is in press in Cell. And so you can look forward to learning more about that. Related to fat because it comes from it. Okay, and we're done. Yes, sir.
So the question that I asked about reversibility.
Yeah.
There are some people, we might personalize this and say, you for one.
I don't know. I haven't had a biopsy of my
another and
hypothalamus.
maintain it.
Yeah. Well, in some of the animal studies, there seems to be reversibility, and that's where where they can change the diet, let things re-equilibrate for a while, and then take a look at the hypothalamus. So I think the answer is probably going to be sometimes it is and sometimes maybe it's not, and that would have to be investigated to try to figure out why sometimes yes and other times no. With people, if you generally seem to need to do something either very robustly sustained behaviorally or physiologically, as in keep giving them drugs in order to overcome this tendency to defend a new set point or settling point. Now, I mean, who knows? We may eventually understand the neuropeptide stuff well enough that we can manipulate it, but that hasn't been possible so far, and that's probably because there's a lot of redundancy in the system. One notion has been this thrifty gene idea, where we have inherited from our frequently starved evolutionary precursors the tendency to store fat when we get the chance, the better to survive the next famine. At the Endocrine Society this time, a grand old man of endocrinology, a guy named Jesse Roth, actually was sitting in a chair and more or less grabbed me to show me his poster, which was fun. And his argument is that actually having some extra body fat helps you survive nasty infections. And he thinks that's why we have this tendency to put on extra fat and keep it the better to survive frequent bouts of lethal infection. And he's got some evidence for that. So maybe that's why. But whatever the reason, I think it's pretty clear that a lot of us have a tendency, given the opportunity with a lot of food available, to just pack it on. And then we tend to hang on to it once we've got it, although exactly how that works, we don't know.
Well, we spend a lot of time preaching that,
I know, not too helpful.
That we shouldn't be obese.
Well, yeah.
And I think there's a lot of good evidence when you look at the number of people with significant disease processes that obesity plays a role in. I mean,
oh yeah,
you know,
of that there is no
cancer,
doubt. Yeah.
Even cancer, for one.
Yeah.
So the question, you know, we in GI end up seeing a fair amount of the effects of bariatric surgery and the negative effects.
Yeah.
And I personally am not in favor of it.
Mm-hmm.
When I see Mayo Clinic push it and other people like that push it. But on top of that, if this idea of the new set point is true, then even that's a losing battle. And indeed, that's what we tend to see, that most of those people end up going back after that typical curve that you have with a 6-month drop over the next several years, 5 to 10 years, going back and even exceeding their original point. So,
yeah, despite how good this data looks, you know, the data is about half the people fail these procedures, you know, substantially. And that's the people you're talking about, the ones who fail the procedures. But still, that's, you know, if you've got half the people not failing, it'll give you a pretty good look at data. Yeah. So I don't know, this is me right here. Over a 7-year period, lost over 30% of my body weight. And that was without drugs, and that was without surgery. And so far, not very long, it's been sustained. So we'll see, time will tell. But, you know, then again, I'm not typical in the sense that I don't think I had that tough a situation that led to my obesity. And then the other thing was, as an endocrinologist, you know, I can't go to a meeting without being bombarded by the negative effects of overweight. And so I have a lot more motivation than your average person because they're not daily bombarded with these things. And also, you know, I did diets from the time I was 14 years old until I started this one when I was like about 63 or 4. So that's 50 friggin' years of practicing trying diets. So I had a lot of, you know, useful experience. Yeah.
Are there any hypotheses in regards to why different people put fat in different places? Is there something genetic that you could say this group has benefited from having it in their tush and this group's benefited from having it in their abdomen?
Well, yeah, it's pretty clear, I mean, just from common experience, that there are some folks who tend to put it in their butt, some people tend to put it in their belly, and so forth and so on. And that presumably has to do with some part of it being genetic load, you know. But we don't really know why.
What drove that?
We don't know what drove that. You know, I mean, when I got this, with this lady with the fat up here, I started making it a habit to ask basic scientists that I would run into, do you know anything about why fat goes where it goes? And, you know, I've yet to get anything other than a blank look. But I think there's enough research going on in the area, we're going to start to get some of that.
There's been some suggestion that steatopigia
right.
seen in Africans
sure.
has some benefit, genetic, you know, survival-wise.
Yeah, could be. Yeah. Baby got back, as the song said. Okay. All right, thank you.